So this lecture includes hepatic and post-hepatic causes of hyperbilirubinemia. So just to orient you a little bit, so here's my liver, obviously, maybe not obviously. Here's kind of my hepatic lobule with my central vein in the middle and my portal areas around the side. Here is a gallbladder, which means this must be the common bile duct. And here's my intestine, obviously, right? So my duodenum. And here's my pancreas. And so when I'm actually going to talk about hepatic versus post-hepatic, a few things to realize is that hepatic means just that. So everything in the liver. So before it gets to the common bile duct and before anything's stored in the gallbladder. So it's before this kind of area here is going to be hepatic. While everything after is going to be post-hepatic. So let's actually talk about how bilirubin then increases with hepatic causes. So the hepatic cause of hyperbilirubinemia is cholestasis. And I mentioned cholestasis before when we talked about induced enzymes, because what happens, what cholestasis is, and I'm going to use kind of a dark gray color, is a blockage of bile canaliculi. And so that's these areas, right? So they're going from green to gray, is that you get blockages within your bile canaliculi or your bile ductules going into the liver. So that bilirubin can't get out of the hepatocyte, and then it regurgitates, right? So it's in the hepatocyte. All right, I made a close-up view. So here we have hepatocytes, and this area here is our bile canaliculus. And for some reason it's blocked. And why things can be blocked, and I mentioned this in the induced enzyme video, is that you could have something like periportal fibrosis, which collapses this whole system and causes a backup. That would be one option. You could have infiltrating neoplasia, right? Maybe it's coming from the GI tract or blood. It's infiltrating and causing a blockage. That would be another possibility. You can have swollen hepatocytes, like if a fat cat stops eating, his hepatocytes fill with fat, get really big, and collapse the canaliculus. So that would be a type of intrahepatic cholestasis. You can get inflammation coming in and obstructing all of these areas. And there's a variety of reasons why you can have that. And that would cause a blockage. And when you get that blockage, this area here, right, that is not easy to see. Let's try a different color. So when you get a blockage there, or any of this happens, this fills up, and so then the bilirubin stays in the hepatocyte, but it regurgitates over into the sinusoids, and then it goes into the central vein and goes into the blood. So that's why you see hyperbilirubinemia. But what you also see, of course, is you'll see increases in alkaline phosphatase, especially in small animals. And again, because the hepatocytes, they don't like this, and so that causes them stress, and so they increase production of alkaline phosphatase. The biliary epithelial cells, the cells that are actually lining the bile canaliculi and the bile ducts, undergo hyperplasia, and that causes an increase in GGT, and the GGT also increases for the same reason as the alkaline phosphatase, that the cells are getting stressed, just the hepatocytes themselves, and making more GGT. So what supports hepatic hyperbilirubinemia and cholestasis is going to be this increase in bilirubin along with increases in alkaline phosphatase and GGT. And all the things that I mentioned are considered obstructive cholestasis. So you have obstruction of bile canaliculi, bile ductules, or bile ducts. And the causes, again, could be infiltrative cancers, inflammation, fibrosis around portal areas. Lots of things can happen. So I'm going to mention one other type, which is called functional cholestasis, which is a little harder to understand. So in functional cholestasis, and we see this more in cats, some sort of inflammatory mediator that's in the body, such as TNF-alpha, doesn't allow the bilirubin to get out of the hepatocyte into the actual bile canaliculus. And so you'll see a slight increase in bilirubin without an increase in alkaline phosphatase. and GGT. And so that one we're really not going to talk about a lot, but I just wanted to mention it because it's in the notes, and that's functional. So there's no actual blockage, it's a functional problem. All right, so the main one again is going to be obstructive cholestasis, with functional cholestasis being a little bit less common. And then the other one that causes hepatic cholestasis is hepatic failure. And this doesn't necessarily always cause it. It's not really the hepatic failure. I think it's whatever the disease that's causing the hepatic failure also causes usually obstructive cholestasis. So that's listed in the notes, but it's really the disease that's causing hepatic failure is also causing cholestasis. So now let's talk about post-hepatic cholestasis. So of course, post-hepatic cholestasis is everything after kind of it gets to the gallbladder. So we're talking about this area here. And this is much harder to identify on blood work with one exception. So things that could happen is you could get a big stone in your gallbladder. That could certainly cause it. That's called a cholelith. You could have some sort of gallbladder inflammation or infection causing an obstruction. Again, that's very hard to identify in blood work. You'd need an ultrasound. So other things, I would say that the one thing that you can kind of identify on blood work is pancreatitis, and Dr. Walsh is going to tell you all about this. So you can see your pancreas, if it got really inflamed, yes, your pancreas and where your common bile duct empty into your duodenum are very closely associated. So if you had severe inflammation in your pancreas, that's going to cause your your common bile duct to essentially not be able to get bile out, and that's going to cause a backup. You can also get some hepatic disease as well from an inflammation and secondary abnormalities within the hepatocytes because of all that local inflammation. But in this case, what you're going to do is you're going to look for pancreatitis. So things that are going to tell you that there's pancreatitis, of course, are going to be inflammation and inflammatory leukogram, usually with a left shift. Remember we talked about hypocalcemia causing it. Often the animal will be vomiting, not eating. They may even have an inflammatory exudate in their effusion. You'll see increases in alkaline phosphatase and GGT because it's still cholestasis. So you'll still see that, but you have to actually look for signs of pancreatitis to support it, that inflammatory leukogram, perhaps clinical signs, and those sorts of things to actually support it. And then you'll learn about other tests that would support it, and one of them is called a PLI. And so we'll talk about that later on in the course when we talk about pancreatitis. The last thing is any sort of neoplasia that's infiltrating. So here's pancreatitis, right? But maybe it's actually a big neoplasm that's causing a blockage. So that's neoplasia there. So neoplasia could cause the blockage as well. Those are really probably going to have to be identified by ultrasound unless you have something like lymphoma and it winds up circulating in blood.